Hello, my name is Jacob. Today, I'm gonna be at SPTA. We're gonna be talking about Charcot Marie tooth disease. So, Charcot Marie tooth disease is gonna be one of the most commonly inherited peripheral neuropathies, meaning that it's hereditary, and it's also gonna be a progressive condition as well. And so, how this affects the PNS specifically, it's going to be targeting those Schwann cells that are responsible for producing that myelin. And the myelin itself is going to be an important part of our body that's going to be sending those nerve signals. And the conduction of those is important because if they're damaged, it can cause any sort of like motor impairments or motor delays. So we need those messages sent as fast, and that myelin helps it send that message pretty fast along that nerve axon. And it's going to be inherited through some sort of either autosomal dominant or autosomal recessive or X-linked gene, and it's pretty prominent in teenage years and early adulthood too, or maybe around like the age of 20s when symptoms start to appear. And so with the presentation of it, the earliest signs that you're gonna see CMT presenting are gonna start in the peroneal nerve down here, where the legs are at. And so when you see that, it's gonna be distally involved with the lower extremities, specifically the foot and the ankle. And some of the signs that you're going to be seeing that are pretty hallmark to Charcot-Marie tooth disease, it's going to have some distally symmetric muscle weakness and often some atrophy with that as well. You're also going to see some foot drop with the dorsiflexors and a lot of peroneal muscle involvement. We're also going to have some diminished DTRs, specifically at the ankle. That's where it starts, right? And we're also going to develop it's going to look like a contracture. It's going to kind of look like this. This is called pes cavus, and it's going to be that high arch, and you're also going to get those hammer toes as well, which is pretty common. And so later stages of CMT or Charcot-Marie tooth disease, we might get some forearm involvement as well. And we might also get some sensory and proprioception loss. This is just pretty common because it is a lower motor neuron, and it affects the PNS as well. And so these impairments can also really affect our gait, balance, and fine motor functions as well. And because CMT is a hereditary uh, condition, there's not that many risk factors aside from having a family history of the disease. There's currently no modifiable risk factors, but early detection and management, or early detection helps with management and improving the overall quality of life. So the way that Charcot-Marie tooth disease does get diagnosed, you can do like a combination of things. So you can either do a nerve biopsy, which is where they take a piece of your nerve, and they look at it to see if you hold Charcot-Marie tooth disease, if it's present within your body. You can do also like what's it called, an NCV, which is like a nerve conduction velocity test. That just sees how fast can those nerves send signals to the muscles. And it's with like a device that sends like a little shock. You can also have like an EMG or electromyography. It's almost like the same thing, where getting that little shock. And these tests help almost like lets us know if those myelin sheaths, if those axons are demyelinated or they still have some myelin left in them. And if it lets us also know how damaged those peripheral nerves are. So some physical therapy treatments. I mean, right now, still working on not fatiguing just because it's progressive. So you don't want to fatigue the patient. You want to work in like a submax setting where they're not being pushed to overly exert themselves to the point of fatigue. You can even use orthotics when exercising to help with like specific contractures like AFOs. Those help reduce any contractures or improve patient balance as well when you're doing exercise with them. And it also stops like foot drop, making gait more functional for them too. Even doing gait training. Gait training is such a good way to preserve that functional tolerance for that patient too. Just because with that contracture, that could really affect how that person is moving too. and the weight distribution on the feet and their balance. Excuse me. Oh my. Excuse me. But moving on, we could also do like passive range of motion stretching. Really preventing those contractures is going to be key to preserving that patient's balance as well. If we can preserve their balance, that is amazing, right? Getting those passive range of motion stretches in to preserve that balance could do a whole lot of difference for this person, especially if you saw these are pretty nasty contractures, and the more that you stretch them and the flatter we can get their feet, the better their balance can become. And overall, just like implementing foot care and education to this patient, constantly reminding them to stretch, right? Just so you prevent that contraction at the toes and at the sole of the foot. And so, due to decreased sensation, it's more likely that these parents can get stuff stuck in their shoe and they won't know that there's something in there, and that could lead to like an ulcer or like a sore, right? And that's going to be a whole secondary issue that they're going to have to face. So just regularly checking their feet to see, is there anything stuck? Do we have any open cuts, wounds? And then, there's this amazing tool. It's a super long rod with a mirror at the end. If they can't reach down, they can put down, look at the bottom of their foot so they have to go all the way down. Amazing. A lot of diabetic patients have it just because diabetic neuropathy. And then strengthening with caution. Try to avoid heavy eccentric exercises too. Those are going to be pretty taxing on the patient. Again, we don't want to fatigue. We want to kind of focus on like some low resistance, low reps, low frequency. We don't want to tire out our patient. We could also practice like energy conservation techniques. You can even go for like good body mechanics, planning out the day, trying to use your energy for certain tasks that are going to be important, using a push cart or some sort of cart to put your items into so you don't have to carry all of them all at once, and just taking breaks before you get tired too. That's going to be a lifesaver for these patients, just because we don't want to fatigue them again. And so, because CMT is hereditary and it's not curable, these like energy conservation techniques, exercise techniques, all of this treatment is just to minimize the effects of the disease. We can't really cure it. So by implementing these techniques with these patients, we are trying to improve their quality of life. And so what we do as physical therapist assistants, we are trying to improve their quality of life by teaching these individuals how to implement these techniques into their daily lives, so that by the time that we're able to discharge them, they can do this on their own, and it's more of a routine for them rather than, oh, I have to go to physical therapy and I have to do this. But it is our job. We are also educators too to our patients, and we are doing them a service by educating them with our knowledge. So by being able to explain it with clarity and simplicity to them, this can make a whole difference in their lives. And I just want to say thank you for letting me speak with you. And if you have any questions, go ahead and email me. Thank you.